So yesterday we finished this station 1, long case, how to take a long case, what are the components of a long case, what they ask in the exam, what is the marking scheme, what is the, so I taught you in the first 10 minutes how to take the history in that 10 minutes, then the last 10 minutes how to spend with the examiner, what is the discussion part in the exam, what components they ask in the exam, right? What components they ask in the exam, what are the components that they test in the exam, all that we did yesterday in the station 1 discussion, long case discussion, and then we played a video also, sample video, how you need to take a history and all that, right? So today we are come to the second part of these free lectures. So today and yesterday I have posted a diabetic case, a diabetic long case, what components you have to ask. So like, I mean, don't worry, that's a huge paper. You don't have to ask all that in the exam. I mean, if I tell that I am an idiot, why you can't ask all that in 10 minutes? Like, it's unbelievable. Huge wealth of information I have given there in that, diabetic history taking chart. But in that, guys, all the possible diabetes related long cases I have given there. Do you know, in your exam, the commonest long case that you are going to get would be diabetes and diabetic related complications. Remember, so if you got if there are 100 students here or 200 students here, at least say 120 students will get a case of diabetic related complication. That much of common, or I would say 50%. Like, I mean, I would say 120 out of 200. So maybe at least 100 students are going to end up with a case of diabetes. Not just simple diabetes, it's a diabetic complication. So I have cases of diabetes with pyelonephritis, the commonest long case that we give for Erpm exam and also finally MBBS, because me being an examiner and sitting with the other co-examiners in the 2 exam, we know exactly what we have given as long case, what we choose for the exam and what we ask in the exam and how we give marks. And that's what I'm telling you all and teaching you all. So I have given you a free handout about diabetic history taking, what the questions you need to ask, how to deal with all the microvascular complications, how to deal with the macrovascular complications, and all the possible presentations of diabetes. I have put A, B, C, D, F, G, H. You would have gone through that, right? So there's beautiful explanation of diabetes. If you have read that, then our diabetic, when we are doing the true long case scenario, that is now first we are doing the station 2, that is short cases, starting from tomorrow. So we're finishing all the short cases, and then after that you again register for the long cases, and that long case in that long case we'll be doing diabetes separately, right? Okay, so guys, we have done all that. And also I posted some very important thing for your Erpm Part C, VIVA, emergency VIVA, that is your X-ray made easy, and also the free, it's a completely free, X-ray video class, and also ECG made easy. I have posted today the PDF format, but that I will be doing a class when you are doing the true, like Erpm Part C. So today we are going to discuss Erpm Part B, the Station 2, that is your short cases, what we are going to start from tomorrow. So we are going to discuss like briefly what components they ask in the station 2, that means short cases. So yesterday I told you they have 2 short cases lined up for you in the true exam. Each short case you have to spend 10 minutes with the patient, so totally it's 20 minutes. So 2 short cases from 2 different systems. So here I will show you now I'm going to show you the marking scheme. I'm going to show you the marking scheme of Erpm exam. Yeah, so you are sharing the same screen with me. So this is the short case marking scheme, marking sheet. So you can see here there are 2 short cases, short case 1, short case 2. This is what we are, the components that we analyze. This is the index number. So marks out of 10 we give, and then multiply that by 10. Or we just multiply that by 5, and the next one also multiply that by 5. So Right. So here you can see short case 1. So when you go to the short case 1, so these are the components, short case 1 and short case 2, that we analyze. So what are they? We may, as I told you yesterday, we may analyze your examination technique, your examination skills, or examination technique. The technique of proper examination of a patient, you get a huge component, right? You get huge mark for examination technique. These are not equal marks, guys. These are not equal marks. These 1, 2, 3, 4, these 4 components, there are no equal marks. Like examination technique, usually we multiply that by 5. Here we again multiply that by 5. And these two, we multiply that by 1.5, something like that. I can't exactly remember. But what I'm telling is, for examination technique, you get a huge mark. Examination technique. So your examination skills, or the process of examination, system examination. So you are supposed to do the cardiovascular system examination. You are supposed to do the respiratory system. I mean, the two systems out of the 4 systems, abdomen and also nervous system. Nervous system, we don't give you all 4, either upper limbs, lower limbs, or cranial nerves, or the cerebellar system. Right. So examination technique, you get a huge component. Then you have interpretation of physical signs. So next thing is you present to the examiner how to present this short case. So that I'll be showing you videos today how to deal with these sample presentations of a short case. Right. So interpretation of physical signs. And that also we give a big component, like again that will be multiplied by 5. So you get a big component in your short case. Total mark, out of the total mark, examination techniques and interpretation of physical signs. The first 2 components, they have a huge component. They bear a bigger weight. They have a bigger weight from your total mark. Examination technique and your skills, and also interpretation of physical signs. So that's why I always say, even if your diagnosis is wrong, still you won't be failed. As far as you have done the examination technique perfectly, and also you have interpreted the physical signs perfectly, you can pass the exam. Then the differential diagnosis. So at the end of interpretation of physical signs or the sample presentation, so for each and every short case in the exam, every short case that you get in the exam, under every system I'm covering, every possible system, every possible short case I'm covering, under all the systems, every possible short case, not a single short case left behind. And also for every possible short case, I'm giving you sample presentations, how to present that to the exam. And I'm doing the true cases, like I'll be showing you videos how I present, like in the true exam. So you have to watch that. So I also do the short case just like you all, because those cases are something that I don't know before. So I'm blindly examining that patient like another candidate in the exam, and then present. So after presenting the sample presentations, then we come to the differential diagnosis. You have to tell what the diagnosis is, right? So the differential diagnosis component, very important. So like based on your, so you say, I examine this patient, blah, blah, blah. So I will tell you sample presentations. And then at the end of presentation, you say, in conclusion, my patient is most likely to have this diagnosis. So either you can give a single diagnosis or you can give a differential diagnosis. Say for example, you get an abdominal short case where you got splenomegaly and also the patient got pallor. So if you get splenomegaly and pallor, there are lots of differential diagnoses. So you say, in conclusion, my patient has got splenomegaly and pallor, so I would like to offer differential diagnosis. My first differential diagnosis is hemolytic anemia. Secondly, I would like to consider lymphoproliferative disorders like lymphomas. Then I would like to consider hematological malignancies, conditions like leukemias. So like that, you can give, or even I would like to consider infections like malaria. I'm just giving you an example, splenomegaly and pallor. So like that, you must give a differential diagnosis. For that, we give another mark, very important mark. Right. Then the last component is discussion. If a student has done really well in the differential diagnosis, then we take them to the discussion part. So like it's all depending on the candidate's performance. Some students, they do very well. They finish in about 4 minutes, the entire examination. And when you finish the examination in 4 minutes, we ask, have you finished? Then a confident student, they say, yes, sir, I'm done. And then we say, okay, present your case or present your differential diagnosis straight away. A brilliant student will straight away tell the differential diagnosis rather than presenting the sample presentation. But what I would say is, don't do that. Don't do that. You present the findings. You present your findings first. Because if you just tell your differential diagnosis, they may be wrong and you might fail the case. We don't want to fail the case, guys. You may be the most brilliant student, but still you might make an error and you might fail that case. And you will have to wait for another 6 months to do your internship. Don't fall into that trouble, right? Don't fall into that level. What you do is, you present your findings. You say, I would like to present my findings, right? So you present your findings and then you give your differential diagnosis, right? So in conclusion, these are my differential diagnosis, like that. You give your differential diagnosis at the end of presentation. Okay, so then you can say what your differential diagnoses are, like 1, 2, 3, 4 format, and then so like if you have done very well, if we have enough time, if your time is less than 10 minutes, we will also take you to discussion part. We will ask, how would you like to investigate this patient? And so then you say few investigations. Then we ask, how do you like to manage this patient? Then we ask some theory. We have done that. I have done that as an examiner from the candidates. So we go on to that level, right? So that's the format of the exam, guys. So if a student is doing really well, we want to give more marks. We don't want to fail the candidate. We really love that student. We like that type of student to become interns. And we give more marks to go to a high level in the merit position. So we always give marks. We are not stingy for marks. So that's why I always tell you, we must do the short case examination quite fast. Though you are given 10 minutes and though you are given 7 minutes to examine the patient, please don't take the entire 7 minutes. Try to do it in about 5-6 minutes. So save about another 4 minutes for the discussion. Because a case that you are doing well, you must score the maximum. That's our target. Just like how we trained our theory students brilliantly for, like I told you, a single best answer question. That's the key. So like I train you all to get maximum marks in single best answer questions, like 19, 18 out of 25. Then you are in a the driving seat, winning seat. So same thing for short cases. Short cases you must do very well, right? Because long case, hardly a student will fail the long case. Everyone, I mean, you should know, once we train you, everyone will pass the long case. But short case, you should target very well, right? So, so the marking scheme, you saw the marking scheme. So number 1, examination technique. So that will be training you very carefully and in detail how to examine the patient. Every single step, like how to keep your feet, like simple way. Because I know students might think, this is silly. He's trying to teach us examination technique. We have been in Russia, we have been in China, we have been in India, we have been in Philippines, we have gone to the walls, we have done the examination. But guys, I do some free hospital visits. When you come to the hospital and when I get you to examine the patient only, you can dig a 6-foot, hole and you can jump into that, right? Then you understand where you stand. You have visited hospitals, but learn like this. Don't worry. That now don't have any hard feelings. Your seniors also were like that. We trained them, and now they are interns. Not only interns, they are RHOs now. They immediately passed. The batch which immediately passed. RHOs, and some of them are post interns, and some of them are now registrars. They have done post registers and registrars, and some of them are senior registrars. Some of my students, older students, right? Okay. So a long case marking scheme I will give in my due course, right? So long case marking scheme I won't show now. I will be giving that only in my long case our course, proper course, right? Okay, because I'm not supposed to show these things too much, right? It's not good, right? Right. But short case I just briefly showed you, right? Okay, so so the short cases are so important. So I will teach you. So that's why I said, wherever you are coming from, don't worry. We will train you right from the basics. right from A to Z. So I'll teach you how to keep the fingers, how to auscultate the patient, when to keep the diaphragm, when to keep the bell of the stethoscope, how to turn the patient, what is called augmented maneuvers in cardiovascular system examination, how to look for the mitral stenosis member, how to feel for thrills, how to look for parasternal heave, all that we train, right? Because I show that, I demonstrate those things on a patient, true patient. And while showing the patient, I am teaching you. So that's why I said video assistant. Today I did that for you. For tomorrow's lecture, I did it just this evening at around 3:30 in the evening, and also yesterday. So very hot, right? So that's how we are teaching. I show you how to do the physical examination, everything. How to hold fingers, how to abdominal palpation, how to go for the spleen, how to go for the hepatomegaly, what is called superficial palpation, what is called deep palpation, all that I'll be showing. So that is examination technique. You have to master your examination technique because you get a big mark for that. And also guys, I want you to do this. I have done this for all your past senior students. What is that? I want you to take, I want you to make pieces of cardboard of about this much. So this is my, the size of an iPhone, maybe iPhone Plus, something like this. So maybe, say maybe, how much, 6 inches? I think 6x4 or 6x5 card. Maybe cards all. I want you to make 6 cards. This you have to do. Because guys, I want to make sure you pass the exam. That's all. Like this you got to do it. You can't do it just before the exam. And during my classes, you need to do it. So you have to take, just 6 pieces of cardboard. For cardiovascular system, 1 card. Respiratory system, 1 card. Abdomen, 1 card. And upper limbs and lower limbs, 1 card. Cranial nerves, another card. So 5 cards, not 6, I'm sorry, 5 cards. Right? CVS, RS, abdomen. Then upper limbs and lower limbs, 1 card, cranial nerves, 1 more card. Okay, you have to do this, guys. I'm going to ask you to show me this card, right? Like when I'm doing this, so you have to do it. So, like for example, tomorrow I'm starting with the cardiovascular system. So in this cardiovascular system, so in this card, so just imagine this is a piece of cardboard. On the front page, you will draw a picture of a man, and you will write what components in general examination that you got to see in the cardiovascular system, or that is what we are writing is examination technique. We usually now, like there are 2 methods of doing examination. One is you can start with the general examination and then go for the system examination. But I would prefer if you do the system examination first and then proceed with the general examination. And that is what all of my colleague examiners also want. Because you will be tested by my colleague examiners, my colleague consultant physicians, where I sit with them for the exam. But now I have withdrawn from the Erpm exam because I'm teaching you all. So earlier I was teaching, but then I was also going for the exam, but I thought it's a bit unethical to teach and go for the exam. So I'm not going for the last 2-3 years for the exam. But before that, I have been an Erpm examiner, and still right now I'm a current final MBBS examiner. So we know exactly what we ask in the exam. So I know what exactly your examiners, who are my co-examiners, what they are going to ask in the exam. So your examination technique, you need to write down cardiovascular system. Start with the head. So tomorrow I'll be teaching this. Start with the head. So how you make the card I'm telling. Start with the head. So head, you draw a picture of, I'll do that for you. This is the card. So CVS. So you must use beautiful colors, right? Different colors, make it very attractive. And you must use only small letters, small print for it. So first you draw the head. Head. So what you are going to do? First, you write here. Peripheral stigmata of infective endocarditis. You write like that. So you know what you are looking for. Clubbing. You look for splinter hemorrhages. You look for Janeway lesions. You look for osseous stenosis. Right, like that. You give a small breakdown there. Then in the hand, the next is, so you draw here and you put an arrow here to the radial pulse. So pulse, rate, pulse, rhythm. So you put shortened forms, rhythm. Then volume. Then collapse in pulse. So I don't have space, guys, because these big letters. So, but when you make a card, you have enough. You can ask from your series how they did it. So like the pulse. Then, so this hand, then radial delay. Then you move to the neck to examine the JVP. So like that, you will be writing your examination techniques, guys. You are not writing another sort of another Word document, right? Just in point form, what you are going to do in the exam. What components you are going to examine. Like that, you do the whole thing. And the next page, you do the system examination. So it's general examination, and the next, the other side of the card, system examination. So for example, cardiovascular system, precordial inspection. What components you are going to see? So surgical scar marks, obvious chest wall deformities, visible pulsations on the precordial. Palpation, what you are going to do. So next heading, palpation. This is the second side of the first part of the page. The front page of the cardboard is the general examination. Second side, system examination. So because cardiovascular system is little different to other systems. Cardiovascular system, we start with the head, we go to the pulse, JVP, blood pressure we usually don't check, then go to the head and neck, and then come to the precordial. But other systems, all the other system, respiratory system, abdomen system, first you examine the respiratory system, chest, or you examine the abdomen, then go to the general examination. So in respiratory system and abdomen, the system examination come to the front page. Sorry, put it there. Simple thing. Then system examination. So what you got to do? So you write them in point form and color them, beautiful colors. Make that card very attractive. Guys, when you are coming to our hospitals, and also when you are going to other hospitals, wherever you can have access, you wear your lab coat, overcoat, clinical coat. In that pocket, you put these 5 cards. So whatever you forget, you read that. Right. This one I have to see, this one I have to see, the other side also you have to see. So like that, you refer these 6 cards. Not only that, when you come home, you keep these 6 cards in front of your table. And every day you are going through these 6 cards. It's like a card pack. Every day you are going through these, not 6, I'm sorry, 5 cards. Every day you are going through these 5 cards. So guys, at the end of the day, these examination techniques are at your fingertips. Otherwise, guys, if you are waiting to try this examination at the last moment in the exam, you are definitely going to fail the exam. I will stand on my head and tell you would have scored 70% for single question answer questions. You would have scored 65% for the MCQ, and you would have become the best student in the theory exam. But if you haven't examined at least 10 patients, from all systems, if you are going to examine the patient for the first time in the exam, I will stand on my head and tell that student is going to fail the exam. You may be the best brilliant student in the theory exam, but you are going to fail the clinical exam. Why? Because you need to have proper training. That is why these classes are there for you all. So we teach you. So I bring the patient to your doorstep. Why? I'm showing you all those examination techniques. And I teach you, I show you how to do the examination. And also you will be coming to hospitals and we will be examining patients also. So then you get the true practice. So you have to practice this. And examination techniques, guys, please, now MCQ and single question answer question, you don't have to always follow what the teacher says to. You don't have to blindly follow. When I teach something, you have a brain, you scientifically analyze and you follow. But here, I'm telling you, blindly follow me. Sorry, I'm not trying to be a dictator. Blindly follow me because I love you all so much. I want you to pass the exam. That's what I'm saying. After the exam, Ani, sir, you will say, Budu, sir, karapu deni sahapi godagiya. That's what they say. Right? That's what they say, right? Because guys, you blindly follow this. So I'm teaching you examination techniques. You examine your mother, father, they'll be happy. Oh, right, my son, my daughter has done really well. He wants to examine and pass the exam. I should help him. They'll be loved. They will love you when you start examining them. So do the examination technique on your mother or father or your grandma or grandpa or maybe your fiance. Put them on the bed, but examine. Nothing beyond that. Right? Okay. You have to be decent. Right? Okay. Because you have to pass the exam. So or your friend in the boarding place. So do the examination techniques. Try them on your friends and get your examination techniques before you come for the hospital visits, before you go to the exam. If you are waiting to practice this for the first time in the exam, you can't pass. You can't pass. You have to practice. I mean, normal I have to practice because you should know how to palpate the pulse. You should know how to palpate, how to feel for the character of the pulse. You should know how to palpate for the volume of the pulse. You should know how to perform the collapsing pulse. Right? You should know how to palpate the apex speed. First try on normal people. Straight away don't go and find aneko mitral stenosis case එකක් තියෙනවද ward එකේ. Mitral regurgitation case එකක් තියෙනවද ward එකේ. එහෙම කියන්න එපා. Like a beggarman. First because every day you don't get these cases. First try your examination techniques on normal people. Get your examination technique correct. Improve your skills on normal people, your friends and family members. Please, I beg you, please do that for me. Because I just want to pass the exam. Please do that for me. Right? So I worship you all and ask that favor. Right? You must start doing that from tomorrow onwards. Right? Because your examination, do it several times. No, I swear. So one student asked, "Sir, can you do CT and MRI as well?" Guys, I know in certain classes, certain teachers teach you CT and MRI. They never ask this. They never ever ask this. So if I want to charge some more money from you, I will do a CT class and MRI class, but they never ask this from you. Okay? So I'm not going to do ultrasound scans, CT scans and MRI because they don't ask that. I will do that later on as a free class to you all one day. CT scan interpretation and MRI scan interpretation. But I will stand on my head because I'm an examiner. More than all the other teachers, I know about the exam format because being an examiner, they never ask CT. Because you are not supposed to give. It's a violation. Why is a violation of exam rules? So even for final MBBS, we don't give that. So not you all. We just give you a simple chest X-ray and a simple ECG, if at all, to interpret. And most of the time we don't give ECGs, but we might sometimes, like emergency VIVA. So I'll answer the chat little later because otherwise, if I answer all the chat questions, the flow of the lecture will get disturbed. Right? Okay. So So I was talking to you about these short cases, and also I was talking to you about this examination technique. So please, guys, please do practice the examination techniques on your friends, family members, and practice it. Okay, you don't need to always go behind patients. The May Sati Dekar, starting from tomorrow, this week and the next week. Now tomorrow I'm doing finishing the cardiovascular system examination, right? The next day I'm doing the short case discussion. So tomorrow when I finish the cardiovascular system examination, you must try on normal people, right? So when you come to the wards, your fingertips know, right, make a step bigger. Otherwise, you have to all the time refer to your book. Tricordium, the apex. You can't do that in the exam, right? You become a clown in front of the examiner. We don't want that to happen because you want to score more marks in the true exam, right? So examination technique. And guys, for the sample presentation, because interpretation of physical science is the second component, we give you sample cases. And for that also, I beg you, you must do one more thing. What is that? You have your own friends, and also you can do it for yourself. You all have smartphones, and you all have this one. You all have the video recorder. right? You all can do the voice recording. I mean, there are other apps also. So you all can do voice recording. So the presentations that I give, you by heart that without looking at the paper, you go in front of a mirror while you want to see your own facial expressions and you present the case. And you turn on your voice recorder and see whether you can, whether your presentation skills are good. So there may be a lot of errors when you, because guys, is like when you are just listening to the lecture, you might think, you be kindergarten students. No, guys, when you try to present only, students get stammering, students they get thought block. They start with the cardiovascular system and then jump to the respiratory system. Right? I know this because I have trained students for years and years and years. Right? General examination cardiovascular system respiratory system. So this happens. That's why I say always practice your presentation skills by yourself. So guys, there are a lot of things that you got to do. I mean, even without going to the hospital, without seeing the true patients, there are lots of things that you have to practice for yourself. Right. Then, so as I told you before, you can come to my hospital. I'm the boss. So like, I mean, you can, no restrictions at all. Like, I mean, like groups of 10 can come. Like we can accommodate more than 10 students in one, like on a day. So like, I will appoint some coordinators. They can make some groups. So you can do hospital visits because it's just 1.5 hours drive from Colombo, my hospital. So like whenever there are cases, we can do sample long cases, sample short cases. This of course full of short cases. So you can practice for yourself. All right. So I gave you a brief overview of Part B, Station 2, short cases. So once you finish one short case, then they ring the bell after your discussion. At the end of 10 minutes, then you move to the next short case. And the next short case, like most of the time there are 2 examination panels, but sometimes 1 examination panel will be there for both short cases. That varies from hospital to hospital. Okay. So we can't exactly say whether you will have same panel for both cases or different panels for both cases. We used to have 2 different panels, but I know in certain hospitals they have 1 panel for both short cases. Right. Okay. So let's see how we teach this in the exam, or before that I'll show you the top secrets. All this I taught you yesterday. So guys, don't get carried away with this one. It's not just 45. You have to score 50 plus for the short case. Please, you have to score 50 plus for the short case. You cannot compensate from the other subject. Because if you read this, you will clearly understand what they want. 200, minimum of 200 out of 400. So all these we did yesterday. Station 1, there is the long case. Right. So the action plan for a definite pass in Erpm Part B and C. Station 2. So short cases are more challenging, but you can easily get more than 50 marks for each case if you know these simple stuff that I'm going to tell you, the top secrets. So the art of clinical examination and interpretation of physical science, that's the most important thing. Art of clinical examination and interpretation of physical science. So timing is usually 6 minutes, though they give you 7 minutes. So you try to finish it in 6 minutes and organize your thought process in about half a minute. And then you have to, because you have to organize your thought process, organize your differential diagnosis in about half a minute, taking half a minute. And then you spend the next 3 minutes with the examiners, they will ask you, present your findings or present your differential diagnosis. So for the organization of your thoughts and to make differential diagnosis, you may take either half a minute or maybe 1 minute. So the art of presenting a case and giving the relevant differential diagnosis, yes, you should know how to master those skills which we will train you. What examiners are interested in the exam, the common questions you should know. So these are the things that you have to learn, guys. So the art of clinical examination, that is examination technique. You need to know how to interpret physical signs in that individual sample short cases. How to arrive at a differential diagnosis. How to do it in 6 minutes. That's also important. How to organize your thought process and give the differential diagnosis in last half a minute to 1 minute. And also how to present the differential diagnosis to the examiner. That you need to understand. And also you need to know what are the common questions they ask in the exam and the common short cases. So station 2, you need to know you need to know the common short cases they give in the exam. So all the possible short cases, not only the common short cases, all the possible short cases in the station 2 I will be covering for each and every system. Right? So when you know the sample presentations for those common short cases, the exam will be just like another cakewalk. Like I mean, just walk through the halls and you will pass, because it's another class, like, because you have been trained for all that. So these are also very important top secrets. Did you know your personality? Yes, it's very important. Some students, they get very stressed up, they're very anxious, very nervous. No, the examiner will not like that, because doctor should be a very sort of a calm and quiet person, but very strong and confident. Calm, quiet, but very strong and confident person. So your personality is very important. And also bedside manners. You will be getting marks for bedside manners. So always right side of the patient. So you approach the patient from the right side of the bed. And hand hygiene, you put some alcohol gel and rub your hands. It's very important. The introduction, how you introduce yourself to the patient. Mama avasan wasari vaidya shishya, mama oyawa දැන් පරීක්ෂා කරන්න යන්න. Right? I'm finally a medical student. I'm going to examine you now. Right? So tell that. And also maintaining privacy, and also like for a female patient, having a chaperone. That is very important. So those are bedside manners. And gentle handling, the gentle handling of the patient. Being gentle towards the patient are also tested. Very important. Guys, not that much tested in the final MBBS or Erpm exam. But guys, in MRCP exam, if you just see, if you if your voice is sort of commanding, so you tell the patient like, "Siya husma ganni hela pahala." So you want to say you are examining the respiratory system, so you want to examine the breath sounds. You say, "Siya then husma ganni hela pahala." The foreign examiner doesn't like that tone. Siya then husma hela pahala ganna, and that's the tone. See the difference. What is your nature? Siya, ganna husma hela pahala. Right? See the difference. Guys, those things will be given marks. You might think this is a joke. No, this is not a joke. Examiner's perspectives. Examiner's experience anatomy. Right? So we want you to be gentle doctors, not so rough handling. You will get a big negative mark if you have rough handling of patients. A big negative component for rough handling. You should never ever do that. Rough handling of patients. The patient can, when you want to get the patient to the seated position from supine, you must put your hand and get the patient nicely to the seated position. Talking to the patient, you can say Tata poddak indaganna or Amma poddak wadi wenna, Achi poddak wadi wenna, like that, but don't go and call 40-year-old people or 50-year-old people Achi and Siya. You will be slapped. You also about 27, 26, and you go and tell the patient, a 40-year-old patient Achi, or 50-year-old patient Achi or something like that. They'll get very upset, right? So don't do that. You have to be you should have some common sense. So like, yeah, or you can, you don't have to say Amma Tata, all that. You just say Punda Vadi Vena Puluanda, then Husma Ganni Hela Pahala. So have minimum addressing the patient. Don't all the tata badiven, tata atadin, tata hiraven, tata katarin, katapumban, all the don't all the time use tata and up and all that. That's very jovial, because you become very unprofessional if you do that. Okay, so don't try to be unprofessional in the exam. You must show your class. You have to be very professional. Okay, right. So gentle handling of the patient is so important, and thanking the patient. So once you, and female, guys, another very important thing. Luckily, I remember that. Guys, now examination of the cardiovascular system and the respiratory system of female patients. Now, guys, cardiovascular system examination, you have to expose the precordial. The anterior examination of the respiratory system, you have to expose the chest. So female patient, you cannot just expose the breast. So like when you are examining a female patient, like, I mean, you should be put them sort of a gown-like thing where you can just untie, like there may be a knot. But all patients are not having that. Some patients might come with their normal blouse or something like that, or their frock. So then you must tell the chaperone, I would like to examine these patients' chest. Could you help me? So like they should maintain privacy. You should make sure that the curtains are put and curtains are drawn and the privacy is maintained. So, and also guys, when you are doing the general examination, please don't expose female patients' chest. It's very unethical. Some students have been doing this and we have failed them, because that's the person who doesn't know how to respect their mother and maybe sisters or wives. So because you should never expose a patient unnecessarily, right? So female patient particularly, when you are examining the cardiovascular system, straight away you don't have to expose the chest. When you are examining the hand, you don't have to expose the chest. Only when you have to examine the chest, you have to expose herself, right? The precordial examination. Until such time, you can keep yourself covered with a cloth or bed linen or something like that. Okay, so it's very important that when you handle female patient, that you maintain privacy of that patient, and also having a female attendee or a chaperone, right? So that's very important. Those bedside manners, you will be given marks for that, and also thanking the patient. That's important, right? So having understood that, we will see how we will proceed with the short cases. Yes. This is very important. Learn the art of doing every case as a fresh case, because if your first short case is bad, you forget that and you move to the second case with a fresh mind. So what training is given to be successful in station 2 in our classes? So we will be teaching you all the common short cases that will appear in the exam. I'll be training on a targeted system examination, like how to do the examination techniques. Very carefully I'll teach you, this is the way to examine, these are the physical signs you would see, and I will teach you how to interpret the physical signs. So we'll be giving lecture notes, video demonstration, a live demonstration of patients, all that I will show you. And also I'll teach you how to time the examination and also interpretation. And the most important one, the sample case presentations for all the short cases. For all the short cases, we'll be giving sample short case presentations. So exam will be very easy for you, because you know what to present in the exam. What I give is a sample presentation. Say, for example, guys, I give a sample presentation for a sample case of mitral stenosis that you can't apply to your patient, right? I mean, your patient might have different set of clinical features, but I'm giving you a brief overview. So learn that and apply from your physical science of your individual patient. Apply that knowledge and make your own presentation. So sample case presentation of the common short cases. Training on presenting the differential layers. I'll teach you how to present the differential diagnosis based on the common short cases. And the most important thing is practice and practice and practice. First, practice on your family members and friends about the examination technique. Alright, so let's see this video which I have done, how to present short cases, how to do the short case like in the true exam, and how to present them. I hope you guys are sharing the video. Is that correct? Green page is there? Okay. So now we are coming to Erpm Part B, Station 2, that is short case examination. You will be given two short cases from two different systems, and for each short case you will be given 10 minutes. So 10 minutes, 10 minutes, 20 minutes. So now today we are going to do an abdomen short case. So the command that will be given to you would be examine this patient's abdomen. So you start with the abdomen and then do the relevant general examination. That's the easiest. Rather than starting with the general examination and going to do the abdomen examination is better. Yeah. So guys, now abdomen and respiratory system. So abdomen short case and the respiratory system short case. Usually we start with the system first. That is, you examine the abdomen. Exam tips. First you examine the abdomen and then you go to the general examination. That's what we want from the candidate. The respiratory system also, first you examine the respiratory chest and then you go to the general examination. Cardiovascular system also you can do like that. But what happens is students might forget the pulse and JVP. We don't want that to happen. So in order to avoid that, we start with the head, peripheral segment of endocarditis, then pulse, collapsing pulse, then JVP, head and neck general examination, and then come to the cardiovascular system examination in the precordium. It's a beautiful way I am doing this. So we have a uniform pattern. I won't confuse you. A nice pattern. So look at it. Do the abdomen first and then go back to the general examination. That's the best way of examining this patient. Now I will teach you some bedside manners. What are the bedside manners? Now when you start examining, you have to start from the right side of the patient. So always right side of the patient. So bedside manners are so important. You must go from the right side of the patient, and before you reach the patient, you must gel your hands. That's very important. And then you must wipe them well and make sure your hands are warm and dry. So the examiner says, this is your patient, examine this patient's abdomen. So now this is a female patient, I am a male candidate, and I have to make sure that there's a chaperone. So if there's no chaperone, I have to ask. So you can see that there's a chaperone here. So there will be a chaperone. Right. So you have to make sure if it is a female patient, and also the necessary curtains should be drawn, because the privacy of the patient should be maintained. And then you introduce yourself. Amma, Mama, and remember you must finish your examination. So I'll be showing these videos and teaching this when I'm doing the abdomen short case. So like that may be I think our first, second, third, fourth class. Fourth class will be doing this abdomen short case examination, examination techniques and all that. So you can see the adequate exposure. See, look at this. So this is a female patient. You can see a nice bed sheet is put here, and patient has been exposed the abdomen up to the sternum. But here you don't have to examine her breasts. Exposure is up to the sternum and to the pubic symphysis. All right. About 5 minutes, then you must organize your thoughts in the next 2 minutes, then next 3 minutes for the discussion. Mama අවසාන වසරේ වෛද්‍ය ශිෂ්‍යෙක් මම ඔයාව පොඩ්ඩක් පරීක්ෂා කරලා බලන්නයි යන්නේ බඩ රිදෙනවද කොහෙවත්? Right. So this is the funny part I want to say. Now these students are laughing at me. Sorry, the patients are laughing at me. I am a consultant physician and like also teaching doctors, training doctors, I'm not saying, not mostly, but high profile person. But I'm a medical. Mama, today when I did this, one nurse, he was looking like that at me. Right? And I said, "Avasan nursery vaidya shishi. Ogulinda mama parippu kana." Hari. So first is inspection of the abdomen. Inspection of the abdomen. First, I'll start at the foot end. Foot end. So the exposure is very important. So the abdomen should be exposed up to the symphysis sternum and also up to the pubic symphysis. Right? This is the area of the abdomen that we have to examine. So I will go to the foot end of the patient now, and I will slightly bend down and see whether the abdomen is distended. Whether the abdomen is distended, and also that distension when is symmetrical. Her abdomen is not distended, and it moves with respiration and is symmetrical. And also I will see whether umbilicus is everted or not. Umbilicus is not everted. Then I will see whether she has got any surgical scar marks. No, I can't see any surgical scar marks. And also whether there are any distended superficial abdominal veins. No, she has not got any of that. Only she has got some the striae, white striae. They are not abnormal. You after pregnancy in females you can see that. Right. So next thing is now. So inspection part is over. Then I'm going to start on palpation. So palpation, there are two components: superficial palpation and the deep palpation for individual organs. So before you do the superficial palpation, you must ask, have you got any abdominal pain? Because one principal rule is you should not hurt the patient. Amma bade කොහෙවත් රිදෙන්නවද? නේ. මම පොඩ්ඩක් මම බඩ ඔබලා බලනවා. රිදුනොත් කියන්න මට. හරි හොඳයි. So while examining, you look at patient's eyes, not at your head. Superficial palpation, very gently. So as I keep my hand on the left side of, so this is the order I am going. I start with the left iliac fossa, left lumbar, left hypochondrium, epigastric region, right hypochondrium, right lumbar, right iliac fossa, suprapubic region, and the central umbilical. So let's see superficial palpation. Now this is the way I am examining. Look at my head, the movements. This is how I examine. So as I keep my hand in the left hypochondrium, I can feel that there's something there beneath my head. So I will come to that when I'm doing the deep palpation. So now epigastric region, right hypochondrium. I'm looking at the eyes with the Shigessetti tenderness. Right lumbar, right iliac fossa, suprapubic region, and the central umbilical region. Right. Now I'm going for deep palpation. Amma man දැන් ටිකක් වැඩිපුර තද කරනවා. හරි? රිදුනොත් කියන්න. Yeah, I definitely feel that there's some boggy. So see guys, did you notice? මේක තමයි අපි practice කරන්න ඕනේ. This is what we need to practice, guys. See, this is with years and years and years and years of practice and teaching. We have got this confidence, and very sort of just like eating. When you eat rice or when you use your cutlery, you don't think, no guys, how to do it and all that. So like that, we just do it. But you are beginning your career and to become a clinician. You are beginning your career to become a clinician. So this is the hurdle that you have to jump. So whether you are a good candidate to become a clinician, that's what we are going to assess in this clinical component. So you have to master these physical skills. See how I was gentle to her. See, I was talking to her. Amma oyage bada man ubanna yanne ridunot mata kiyanna. Ewa kiyanna one. Api ahan innawa pitipasida examiners la. Right? So tell the patient, I'm going to press on your tummy. If it hurts, please let me know. If she says, stop your examination. Anni, mama, I need to examine this patient's abdomen. He may be having splenomegaly, she may be having hepatomegaly. I didn't do anything, but she's in pain. What will you do now? She says, Bhatya. What will you do now? Okay, tell me. I want to listen to you. You just did the superficial palpation only. You are not gone for organomegaly. You are not palpating hepatomegaly, or you are not palpating splenomegaly. What will you do now? Go. Here, common sense. What will you do now? Go. No one is answering. Common sense. Very dull. Yes. So iPhone spoke to me, from iPhone to me. So answer was given by iPhone. Right. So you have to stop the examination. When you stop the examination, you tell the examiner, so I cannot proceed with the examination, patient is in pain. So the examiner will come and we always try to pacify the patient. Right. And so guys, when you examine, try to be very gentle. Don't press too much. Right? Don't cause pain. Right? It's very important. Mass, boggy feeling, some mass-like feeling beneath my head in the left hypochondrium. See my movement of the head. Now I'm going to go for the liver palpation. So, right. So I will keep my hand like this, and I'm going to move my right hand perpendicular to her right subcostal margin. So your movement is only during expiration. In the inspiration, you keep your hand still so that you allow the liver margin to come and hit your fingers. See, I'm only moving my hand during expiration. And look at the movement of my hand. Like a wave it goes. Only during expiration. Look at that. The movement is only during expiration. Expiration, I allow the hand to come and hit your fingers. The liver. So I went up to the right subcostal margin. I could not palpate any masses. So I'm going to reconfirm that by doing percussion. See my technique of percussion like this. Your middle finger, middle phalanx, tap with your right hand, middle finger like this. Okay. You can hear the sound. Timpani, 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 timpani. Maybe little dull, maybe she's having just 1 centimeter hypotomically, but that I cannot palpate clinically. Right, that's what. Guys, did you see that? This is another thing that we are closely examining in the exam. Your percussion technique. That can cover it. So left hand, middle finger, middle phalanx. We tap with the right hand, middle finger. In the MEVA, හැමදාම මේ hospital hari to practical class somewhere කියලා දාගෙන even නටන්න ඕනේ නෑ. ගෙදර කරලා you can do these things at home before you truly see the patient. You practice this technique, guys, because when you come for the exam or when you come to hospital visit, මෙන්න මෙහෙම ගහන්න. It's wrong. You cannot have any movement at the head, at the elbow. The movement is only at the wrist joint like this. So you must practice these things. And guys, you see my exam this time. I swear, guys, actually I am so happy the way I am teaching you guys this time, because now I have been teaching Erpm students for the last 15 years. Since I was a small buddy intern, I have been teaching, right? So my first students are even senior to me, right? So up until this year, we could not do this process, guys. But this time, because we were teaching how to examine, like in the class, live classes, but in SIPNA. And also we bring patients. I bring a patient and I keep that patient in front of the class. Then I put you in groups, student groups. So one group go and examine the patient, then second group go and examine the patient, third group go and, like that it goes. Then another patient comes in, and then the other patient comes in. Ini group එකකින් අර මේ ඔක්කොම ඉතින් බලලා නිකන් මැජික් එක වගේ. ඉතින් මේ මම පෙන්නන්න මේ ඇත්ත I'm telling you the true scenario. This is what happened in the true exam. So you wear a stethoscope, maybe a cardiac system. You are not doing the proper examination. So this is just say this is the chest of the patient. And this is the precordium. මම තිබ්බ ගියා. අනිත් එක නාම සෙට් එක තිබ්බ ගියා. තව එක්කෙනෙක් ආව පොලිමේ සෙට් එක තිබ්බ ගියා. ඇයි ඉතින් ඔක්කොම යන්නේ? මේ රවුන්ඩ් යන්න ඕනේ. This is what we did, guys. I'm very honest with you. Right? I'm very honest with you. This is what they did in our practical classes. So they did that. But guys, like some of them haven't heard the murmur. They don't know what the murmur is. Right? They never got the opportunity to spread. You think all students can go and push the abdomen and palpate the spleen? Spleen will rupture. Poor patient's spleen will rupture. That will never happen in any single class, right? So even our classes, we got only couple of students. So like we get about 2 students from one group to go and push the abdomen. The others are watching. They were watching. The students, maybe 2 stories can. Is laughing and chatting. This is the truth, guys. In the practical classes. But now it's not happening like that, guys. Why? Here we teach you, see, even the percussion sound you hear. In our live classes, no one could hear those percussion sounds. Only the student, those who like, so when we ask the student group to come, some students, they quickly come and stay in front of the patient. The others are behind, little shy students are behind. Only very bold and brave students are right in the front because they will be asked to do some examination. So others can't hear you. But here, see, did you hear the percussion sound? The timpani too. So see the value of these classes. This is the way I'm using to teach you, guys. Liver palpation. Liver is not palpable. Then I'm going to go for the spleen palpation. So I'm using my flat of the hand. So starting just below the umbilicus and movement is towards the left subcostal. This is the left subcostal margin and I'm going to go like this. See the movement of the head. Occasionally you look at her eyes whether she's in pain. Usma ganni hela palamma. Yeah, so now here I can feel that something is coming and hitting my fingers. So when I feel something is hitting my fingers, I will tell the patient to take even a deeper breath. Why? To reconfirm that it is a real mass coming and hitting my fingers and not the muscle mass. Definitely, yes. So when I told that, take a deeper breath, definitely a big mass came and hit my fingers, tips of the fingers. So I know it must be either the left kidney or the spleen. Right. So now I'm going to confirm, I'm going to put my left hand to a left loin region. Yes, I can definitely, because your spleen is bimanually palpable. Beautifully I can palpate the spleen. So I'm not moving my fingers, I'm just keeping it there. Now I'm going to see how many finger breadths below the left subcostal margin. This is the left subcostal margin. You can keep a measuring tape and measure that. So if you put finger breadths, it's about 4, 5, 6 finger breadths below the left subcostal margin. That may be about 8 centimeters. Okay. So then when you palpate a spleen, then you have to go along the medial margin and see whether you can feel the notch, because you don't know whether this is a left kidney or spleen. Right. I'm going to do that now. Whether I can palpate a notch. No, I really cannot palpate a notch. Right. Now I'm going to palpate for the consistency of the spleen, whether it's a soft spleen or a firm spleen. It looks like a firm spleen. I can feel a firm spleen here. Now I'm going to confirm the lower margin. So I said about 6 centimeters below, 6 centimeters below the left subcostal margin. I'm going to confirm by percussion whether what I felt is the position, whether it's correct. Look at mine. So again, percussion is perpendicular to the left subcostal margin. Yeah. So here I felt the low margin of the spleen, and the way to measure is like this. You keep the measuring tape at the left subcostal margin, and here this is the place where I felt the spleen. Yes, it's about, it's about 10 centimeters below the left subcostal margin. So you can measure like this by keeping a measuring tape also. Or else you can even use your finger breadths. So it's about 7, like from the fingers, it's about 6-7 finger breadths. That's about 10 centimeters. So percussion is like this, starting just below the umbilicus, tympani, 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 tympani,
Timpani.
Now, guys, listen very carefully. Listen very carefully. You will hear. You heard the tympanic note. That tympanic note. I don't know when the video is lagging, but my internet connection is really good. Good signal strength. I don't know why it is. I mean, there maybe on your side, then internet there's a problem. What you can do is you can turn off the video on your side, no? Guys, can you all turn off your videos so that so then that will be better. Can all of you all turn off your videos, cameras? So basically, I don't want to see you all. So turn off your cameras. Once the video is over, again you can see that. But yesterday we didn't have any lagging like that. Same. Anyway, again, so if all of you all can turn off your videos, that will be better. Can all of you all turn off your cameras? Turn off your cameras, right? Okay. Maybe I will also turn off. Yeah. So now listen to this very carefully. You will hear the classical tympanic note, tuk, 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 and suddenly change over to the dullness where you have the spleen. Then it will like that, it changes. Listen to that carefully now.
See how it changes. Timpani, timpani, dull. See, timpani, dull, dull. Can you feel that? Here it's timpani, timpani, and dull, and again dull, dull. And now I'm going to hit near the left subcostal margin, and again dull. And this splenic dullness extends beyond the left subcostal margin. So I'm going to focus about one space above the left subcostal margin. So you can see the splenic dullness extends beyond the left subcostal margin. So that says it is not the left kidney, it is the spleen. While left kidney dullness stops below the left subcostal margin. Alright. So now I have confirmed that it is a spleen. And after that I have to see whether there are any palatable kidneys. So this is the method of examining palatable kidneys. You give a gentle push like this and keep the other hand to palpate it. There's no palatable left kidney. Now I'm going to see whether there's a palatable right kidney. There's nothing like that. Then I'm going to focus for free fluid. So I'm going to keep my fingers directing towards the feet and focus like that towards the left lumbar region. So you are going to focus and see whether your tympanic note changes over to dullness. Tympanic, tympanic, tympanic. So right throughout tympanic there's no dullness. Tympanic, 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 right throughout tympanic. So there's no evidence of free fluid in the abdomen. Now, if she got a hepatomegaly, you can auscultate for hepatic fluid, but also you will auscultate for bowel sounds now. Yeah, bowel sounds are heard. So I have done the abdominal basic examination. You will also tell the examiner, I would like to examine these patients. I would like to do digital examination of rectum and genitalia examination, but examiner will say no to it. It's okay. And after that, you are going to do the general examination. Right. So now you have got a spleen, and now you are going to see the general examination. So first, I am going to go to her head then and see whether she got any fellow. Amma, uda balanna. So I'm going to pull down her conjunctiva and see whether she has got any conjunctival pallor. She was pale before, but we have given blood transfusion. Now, of course, her conjunctiva is back to normal. Yeah, she
So you can see that. So in that video you saw, sorry, like if there's a small lagging, like I mean this happens, guys. I mean videos we do in certain resolution, but sometimes we do play that any classes will happen. Zoom, when you play through Zoom, there can be small, but it doesn't matter, but guys, because you can watch this even later. Because those who join the group, like we will be giving the video link again, so you can again watch it. So guys, now you saw that. First, I did the abdominal examination, went for organomegaly, did the percussion and all that, look for free fluid, all that I demonstrated to you, and then I'm going to do the general examination. See how I'm teaching. Actually, today I'm not trying to teach you the abdominal short case examination, but I'm giving you overview. How you have to do the short case, how you have to examine patients, how you have to be gentle with the patients, the technique, how it's important. How to do it confidently, and what I am doing for you, what this man Lalindra is doing for you, how Lalindra is training you. That's what I am teaching you, right? So this is a good opportunity to learn how the examination techniques, what you are supposed to do, and how we do our teaching part. Okay. So I'll just play this video fully. The other videos I will not play fully. I will just show you how we do it, like very briefly. So I'm doing the general examination now. Okay, general examination.
We can obviously notice she got mild jaundice, just tinge of icterus, mild jaundice. And I will see whether she got any skeletal abnormalities. Masse podda galavan. She has not got any maxillary hyperplasia. Yeah, so that is another way to look for pallor. Now I am going to look at her fingers, because I am going to examine neck for lymphadenopathy later. I am going to see whether she got any peripheral stigmata of chronic liver cell disease. That is, I am going to see whether she got any spiderema. She got vitiligo, but she hasn't got any spiderema. Spiderema are red colored dots that you can see in the upper chest. She has not got that. Now straight away I am going to her hands to see whether she has got any finger clubbing. So this is the method to look for finger clubbing. I will bend down, take patient's fingers to my eye level. The patient got any? No, she has not got any finger clubbing. That method is enough, right? And also whether she has got any white nails. Why, if you got chronic liver cell disease, you get what are called leukonychia or white nails. She hasn't got that. Then, so clubbing is not there, leukonychia is not there. Then I will look at her palm. Why, if you get chronic liver cell disease, you palpate like this and see whether the patient got any depuncturans contractures. Depuncturans contractures is not there. Depuncturans contraction, you will get a flexion deformity also like this. And also whether she got liver palms. No, she hasn't got any of that. If it is chronic liver cell disease, I will ask the patient to keep her hands like this, look for flapping tremors, but now in her case it's not necessary. Right. And then I go to her feet. I want to go to her feet and see whether she got pedal edema, ankle edema. This is how you test for that. You press with your thumb about 2 centimeters above the medial malleolus, like this, firmly for about 5 seconds. Then release the thumb and just palpate like this, also on this side. I'll get her to sit her up. So I'm going to see whether she got any lymphadenopathy. So this is how you examine first the submental nodes, submandibular nodes, tonsillar nodes. Then I'm going to go along the anterior border of sternocleidomastoid to see whether she got any superficial cervical lymph nodes. But of course you can see she got very prominent carotid pulsations. The carotid pulsations are very prominent. Very prominent carotid pulsations, but she hasn't got any lymph nodes. And then the deep cervical nodes and the supraclavicular nodes. Here I will look for supraclavicular nodes. So no superficial nodes, no deep cervical nodes, and no supraclavicular nodes. Alright. And when you do the abdominal examination, you will also examine her back. Pitocin. Why you are doing that? To see whether the patient got a scar here on the anterior superior iliac spine, to see whether the patient has had a bone marrow biopsy. So she has not got any of that. That's your end of abdominal examination. So you must learn how to present this case. So this is how you present. You never look at the patient and you.
So this is how so that's how you finish the case, guys. Then you must thank the patient, and you must. She was pulling up her dress, so you had to put it down, and you thank the patient. So you must tell the patient, yeah. So then what you need to do is I was reading one of the chapter questions. Is video resolution may be a little too high, so I will have to reduce the resolution in the next few videos. That's okay, guys. We learn from experience, through experiences. This video is something new for all of us, so I think so there may be small hiccups. Don't think that this is just like another teledrama with perfect filming and things like that, but I think it's quite good, quite manageable. The message is given clearly. That's the most important thing. So next videos when we do, we'll try to reduce the resolution. I might try to get helps of Chanuk also and Ravidu also. So we'll do it, don't worry. We'll make you rocky. We'll rock you. Right, okay. In our classes. Right. So, okay, guys. So once you finish the examination, then you have to start presenting the case. Now, very important, when you present the case, don't look at the patient again. Because if you look at the patient, that is cheating. Why? That is, you are doing the inspection part again. So you can't do that. You cannot look at the patient. You have to look at examiner's eyes. Examining right? Examining that's what I say. Right? So you keep looking at examiner's eyes like this. Right? Don't look aside. Don't look down and present. Look at examiner's eyes. The examiners also fall in trouble. It happens to us. Particularly when there's a female medical student, when they are presenting and when they are looking at eyes, our eyes, my God, I feel so different. Like it's a difficult situation, right? So like sometimes, so those are tactics that you can use. Okay, try that, right? So, right. Anyway, so look at the examiner and present the case, and how to present the short case. So the presentation skills I am teaching you in the next part of the video. Sorry if it is getting a bit drag.
The patient and you look at the examiner. Keep your hands like this. I examine this elderly lady. I examine this elderly lady's abdomen. Abdomen was not distended. It was symmetrical. Umbilicus was not everted. There were no scars and there were no distended superficial abdominal veins. On superficial palpation, there was no tenderness, and on deep palpation, I found that she has got a 7 to 8 centimeter firm splenomegaly. It was non-tender, and the splenic dullness extended above the left subcostal margin. No hepatomegaly, no palatable kidneys, and there was no free fluid in the abdominal examination. On general examination, I found that the patient was slightly pale, and she had mild icterus. No lymphadenopathy, and she did not have clubbing. So, in conclusion, my elderly patient has got pallow, mild icterus, and also firm splenomegaly, without any peripheral stigmata of chronic liver cell disease, and without any lymphadenopathy. So the most likely diagnosis I would like to conclude, or I would like to give a differential diagnosis
firstly, I would like to consider hemolytic anemias. I also would like to consider lymphoproliferative disorders like lymphoma, even though she has not got any lymph node enlargement, and also other hematological malignancies. So I would like to investigate her by doing a full blood count, blood picture, a retic count. If the retic count is high, that will favor hemolytic anemia. And also because she got a firm splenomegaly, I will also do liver profile and see whether she has got any features of chronic liver cell disease. I will also order ultrasound scan and see whether the patient has got any evidence of cirrhosis. But in conclusion, like this patient most likely to have hemolytic anemia. Thank you. Okay. So guys, you can come back if you like. You can turn on your videos. Yeah. Okay. Everything is okay. Yeah. Okay. So that's what we are doing in our classes, guys. So you saw how to do the examination technique, and the second part, the big component where you get a lot of marks, that is presentation. Clinical presentation or interpretation of physical science. You saw how I interpreted physical science and my presentation skills. All these things we will be teaching you, we'll be giving you sample presentations. Now this was a case of splenomegaly with Pello and jaundice. Okamatino manga. Package. I have certain packages. I call them packages. For these systems, we have packages. So we have a package for splenomegaly with Pello and jaundice. How to do that case, how to present that case, and how to arrive at differential diagnosis. And I already did that for you. So all that we give you. That's what we do in our classes. Okay, right. So that's how we make it really exam, like an exam scenario. We give you real exam experience through these classes. Okay, so I hope you guys have really enjoyed that video. So that's the format of my classes. I just want to show you. I'll just show you another one. I will not show the full thing because then do that. So just I will skip through some areas. I'll just show you how we are doing the nervous system. So if you don't mind, can you turn off your videos please for a while? We are going to examine the cranial nerves. Another Erpm Part B Station 2 short case would be examine, the examiner's command would be examine this patient's cranial nerves. So you will be told either examine upper cranial nerves or you will be told either examine lower cranial nerves. So now we are going to examine lower cranial nerves. That is, we're going to start from 7. So 7, 8, 9, 10, 11, 12. Okay. Right. So watch me carefully. See mama අවසාන වසරේ වෛද්‍ය ශිෂ්‍ය මම ඔය පොඩ්ඩක් පරීක්ෂා කරලා බලන්නයි හදන්නේ. හරි? හොඳයි. So first you inspect his face. As you see his face, මේව බලන්න මේ පැත්ත. මේ කිලි බලන්න මම දිහා බලන්න. So as you see his face, you see there's a facial asymmetry. You can see his mouth is deviated and his right side of the face is sort of flat. He's only having eye closure on the left eye. His right eye is not closing at all. Can you notice this place? He's only blinking his left eye, but he's not blinking his right eye. And you can see his mouth is deviated to the left side. So this is what we call facial asymmetry. Right. So now I'm going to start with 7th cranial nerve. So 7, 8, 9, 10, 11, 12. Right. So first inspection. So you can see there's a facial asymmetry. Right. See, nalana raligassan me mage
So you can see here, he's getting wrinkling only on the left side of the forehead, but right side of forehead there's no wrinkling. So you can see the wrinkling appears only on the left forehead but not on the right side. So right side forehead is flattened down. Right. And also you can see that he's blinking only on the left eye, but his right eye he's not blinking. And you saw this. Did you notice that? That's called Bell sign. There we go. You can see that the cornea is going up. Did you notice that cornea went up? That is called Bell's sign. So this one I cannot open. He can have tight closure of the left eye. But right eye, you can see he cannot close his right eye and right cornea has moved up. So this is classical paralysis of the orbicularis oculi muscle, and he has got Bell's sign, cornea has gone up. So this is classical right-sided low motor neuron facial nerve palsy. And the next thing is you have to look at the nasolabial groove. So you can see the nasolabial groove on the left side is very prominent, nasolabial groove, but on the right side is flattened. So you got a good nasolabial groove on the left side, but nasolabial groove is flat on the right side. And also you can see the mouth is deviated to the, his mouth is dropping on the right side, mouth is deviated to the left side. So there's mouth deviation towards the left side. See here, can you see this? Beautifully seen. So you can see mouth is being drawn towards the strong side, which is the
So I didn't want to play the whole video because we'll be doing these things under the nervous system. So I just wanted to show you how we do the short case. What is our approach? You saw the fine, beautiful physical science. So like, I mean, when we are playing the, when we are doing the true classes, I will reduce the resolution so that everyone will be able to see perfectly, because there's a small, lag behind. That is because the resolution is high in the videos. So we can do that. Don't worry. These are, I mean, today we just the introduction. This is not a true short case class. So this is what we are doing, guys, showing all the physical science. And that's the guys, trust me, that is the commonest neurological short case we give in the exam. The commonest neurological short case. A handful of short cases in neurology. One is this facial nerve palsy. The other one is we give you a case of stroke, that is with the lower limb weakness or upper limb weakness. Then we also, if there's a case of ophthalmoplegia, like either third nerve palsy or sixth nerve palsy, we give that. It's like that. That's it. Very few short cases, and this is the commonest neurology short case which I showed you, facial nerve palsy. And I have asked this enormous times from candidates. I examine this enormous times in the exams. So we have set of questions that we ask, and for all these things, I will be giving sample presentations, how to present the short case. And I'll be showing you the other cranial nerve examination also. So 7, 8, 9, 10, 11, 12, but I interrupted the video because I didn't want to play the whole video, because this is not a neurology class. I just want to show you our format of the class, how we are going to achieve success in the true Erpm Part B exam. Okay, guys. So you would have understood what it is. So we'll be training you the examination techniques, interpretation of physical science, showing the true cases. Whenever I get a good case, I'll be doing videos and I'll be showing you them. So we try to cover most important short cases which come up in the exam. Alright. And about the hospital visits, so like for dedicated students, like very true genuine students, will be organizing classes. Genuine in the sense, like when you really register, you are eligible for that. Free hospital classes, you are not charged a cent for that, completely free of charge. We get you down on 2 days. Most of the time I do those classes during night time. That's how even your seniors, they came when I was in Norelia, they came to Norelia, and all those who came to Norelia, they are interns. They are Finnish interns actually, internship. So and here this is not far at all, because the time that you travel to Part-2 from Colombo and the time you travel from Colombo to Puliapiti are almost same, because Part-2 you drive in traffic, but here you don't drive in traffic. So it's same distance, right? Okay. So that's it. That's how we are going to do the ERPM Part B. All the short cases we will be covering, and for each and every short case, I'll be giving sample presentations. So guys, I have in my advertisement for your payment, I said it's only 7 classes, but it will be more than 7 classes. I think it will take up to about 8 or 9 classes maybe, but the charge is same. So don't worry, I'll be covering all these things. So regular days will be Tuesdays, Wednesdays, and Sundays. Like sometimes there can be some, yeah, those are the fixed days, Tuesdays, Wednesdays, and Sundays. If you got some free time, I might do some additional classes as well in order to keep the timing right, because we have to cover everything before maybe 3rd week of February, because you will have your exam possibly in the last week of February. So by 3rd week, we won't finish everything. So that's about ERPM Part B. Let's move on to ERPM Part C, that is your emergency VIVA. Yeah, I hope you are sharing the right screen. The action plan for ERPM Medicine VIVA Part C, Emergency Medicine. Okay. All right. So we'll be discussing all the possible emergency topics, particularly the exam favorite topics with clinical scenarios. And I'll be giving printed handouts for all the possible emergency cases that you can get in the exam. So we'll be giving printed versions, what the examiners commonly ask in the exam. So I'll give you examples. So one common case that we give, I'll tell you what I gave last time, what I gave as an example. The final MBBS, same final MBBS emergency VIVA and the ERPM emergency VIVA, 100% same. So I started with, we want to start with MI, cardiovascular system. So I told there's a 50-year-old heavy smoker with diabetes and hypertension presented to the accident and emergency. There's A&E. They usually use this word A&E. Presented to the A&E with severe central tightening chest pain. He was sweating profusely. You are the on-call doctor. How do you tackle this situation? Doesn't it looks like a difficult question in the exam, but you know it's a very simple case. What is the simple case? It's a case of MI, isn't it? Heavy smoker, having diabetes, having hypertension, coming with central tightening chest pain with autonomic symptoms like sweating and vomiting, and that's the case of acute myocardial, at least acute coronary syndrome, and most likely to be acute myocardial infarction. So the examiner says you are the on-call doctor. How do you deal with this situation? Right. So the question is given to you. Sometimes we put the question in an envelope, and we give the question in an envelope, and the student has to open the envelope. When you open the envelope, the question is there. You read it, and you are given a paper. Actually, you will be given papers. So the question will be given to you, and actually we give you a small a sheet. In that the question is written. So you are given about 1 minute to organize your thoughts, and then you start answering that. But every station they don't do that. In Peradini we used to do that, but I don't know about the other stations whether they do it or not. If they do like that, that's better. So, or even verbally, like I remember sometimes we ask verbally. I have done that. So when you are given that, how do you tackle? What is your opening? So guys, the opening statement is the most important thing. Why? That's how you impress the examiner. So you are seated. Now, how the VIVA exam occurs is, the 2 examiners will be on one side and you will be on this side. Okay. So one physician and one pediatrician will be sitting in the medical emergency VIVA. One physician and a pediatrician. In the surgical track, one surgeon and a gynecologist will be sitting. So in the medical track, emergency, it will be a physician and a pediatrician. So we try to, So if the pediatrician wants to ask about anaphylaxis, I'm not going to ask about medical anaphylaxis. We want to go in two different lines. So, so how do you deal with this question if you are a candidate? So then you start, given the case scenario, it looks like acute coronary syndrome, like acute myocardial infarction. So it's a medical emergency. So first of all, I will assess airway, breathing and circulation of this patient, because first of all I want to make sure that this patient is living. So I will quickly assess his airway, whether he's breathing normally, whether he got a patent airway, whether his breathing is normal, and whether his saturation is normal, and also whether he got normal blood pressure. And then I will organize a very urgent ECG. I want to see what the ECG pattern is. But until the ECG is been done, I will also give the stat doses. I will give soluble aspirin 300 milligrams, clopidogrel 300 milligrams, and atorvastatin 40 to 80 milligrams, right, as the stat doses. If the patient's saturation is a little low, I will connect him to oxygen. I can probably give oxygen via nasal cannula or via a face mask. If the patient is in severe pain, I will give him some, and provided the patient's breathing is normal, saturation is normal, and if the patient is in severe pain, I will give him some morphine. I can give IV morphine 2.5 milligrams with IV metoclopramide 10 milligrams. Then by that time I will give the urgent ECG, and in the ECG I will have a look at the ECG patterns. I will see whether the patient has got whether ST elevations, and I will see what leads he has got ST elevations, and also I will see whether the patient got any ST depressions or T inversions. Say if the patient has got only ST depressions or T inversions, that could be other types of acute coronary syndrome, like either unstable angina or non-ST elevation in STEMI. So only in acute myocardial infarction you will get the ST elevations. Then if the time duration, I will ask the patient, I will get a very brief history while managing this acute emergency scenario. I will ask the patient whether he got the true anginal pain for radiation down the left arm, whether he got autonomic symptoms like sweating and vomiting. Then also I will ask the duration of pain, because if the pain duration is more than 4 hours, 4 to 6 hours, I can do the troponin I. Yeah, I would expect troponin I to be elevated if it is myocardial infarction or STEMI. Then, if the ECG shows ST elevations, I will organize thrombolytic therapy. But before giving thrombolytic therapy, I will ask whether the patient has any bleeding tendencies like bleeding hemorrhoids, bleeding peptic ulcers, whether he has any history of hematemesis, melena, or hematuria, or hemoptysis. Because I don't want the patient to bleed into death by giving thrombolytic therapy. So I will ask that from the patient. And I will also make sure that the patient has not received any neurosurgical procedures in the recent past. Patient did not have any hemorrhage into his brain, any intracranial hemorrhages. And I will also make sure that the patient has not undergone any major surgeries during the last 2 weeks, because these can be contraindications for thrombolytic therapy. Then, after excluding contraindications for thrombolytic therapy, I will get patient's consent, and I will organize intravenous thrombolytic therapy, which is tenecteplase, tissue plasminogen activator. But also, on the other hand, if the patient can be transferred to a hospital where the CCU facilities are available, coronary care facilities are available, and if you can transfer the patient within 3.5 hours to a hospital with coronary care facilities, I will transfer the patient for consideration of primary PCI, primary percutaneous coronary interventions. Right? So then after that, so once the thrombolytic therapy is given, then I will monitor ECGs, because I want to make sure patient does not develop any new arrhythmias. So I will do the sequential ECGs, like after thrombolytic therapy, I will repeat ECG in 1 hour's time, in 2 hours time, 4 hours, like that I will do sequential ECGs. Then if the patient is in severe pain, I will give him morphine. And then I will also start drugs with survival benefit. That is low dose aspirin 75 milligrams to 150 milligrams, clopidogrel 75 milligrams, atorvastatin 40. If the blood pressure permits, if the blood pressure is all right, I will start him on an ACE inhibitor and also a beta blocker if he is not asthmatic. Okay, and also in the acute scenario, I will closely observe. I will closely monitor for any complications of myocardial infarction like ventricular tachycardias, ventricular arrhythmias, if the patient has got any other heart blocks, if the patient got any evidence of acute left ventricular failure, pulmonary edema, also with the patient got any acute pericarditis, with the patient got any new onset pansystolic murmurs for acute onset ventricular rupture and VSD, or papillary muscle rupture causing acute MR. So I will look for these complications. Another complication that I can see in the acute phase is when the patient is getting any neurological weakness on one side of the body, that is where the embolic stroke can occur following myocardial infarction. So I will look for these things. So that's how you have to tackle the emergency VIVA, right? So, and like when you said that I will organize the ECG, now I have done that. I gave the ECG to the candidate to interpret. I give the ECG to the candidate. Okay, this is the ECG. Look, have a look at that. So then you take out the ECG and you go through that and then see what the obvious abnormalities. So that I'll be teaching in my ECG class. Like here you will see a nice ST elevation. All right. So, and then you proceed from there onwards the way I taught you. So that's how you manage the emergency VIVA. You understood, guys? You can come back actually. If you want, you can turn on your videos, cameras. So that's how we are going to do the emergency VIVA. So each and every emergency VIVA, short emergency VIVA case will be covering, say, cardiovascular system. Then we also give you acute pulmonary edema, acute LVF. Then nervous system we give Guillain-Barré's. So spinal cord compression, like that. All the possible emergency case scenarios will be covering. And in that part C. So we have 3 courses for this Erpm medicine VIVA exam. The part 1 is what we are starting tomorrow, that is station 2, short cases. Then once we finish that, then we move to part 2, that is station 1, the long cases, which comprise about 5 to 6 classes. But you will be charged only for 4 classes. Now this also, there are about 9 classes, but you will be charged only for 7 classes. Then the part 3 is Erpm Part C, that is emergency VIVA, emergencies, because some students, they have only the emergency component. So the emergency part, we have about 4 to 5 classes, including the ECG interpretation and X-ray interpretation as well. But the X-ray made easy, that video has been already posted. You can leisurely watch that. This is the best time to watch that, because close to the exam you might not have time, because you have to go through 4 subjects. So this is the best time you can watch that video and learn from that X-ray interpretation. But ECG interpretation I'll be doing at the end during that VIVA, emergency VIVA course. Alright, so that is the exact pattern of our class. As a help, guys, I have posted the ECG made easy, my PDF, the PowerPoint presentations PDF format. I have posted in your WhatsApp group. You can go through that. So those are the ECG changes that you need to know. You will be tested only very few cases, only few scenarios you will be given in the ECG, like obvious myocardial infarction or non-STEMI, or obvious complete heart block, maybe obvious Benkiba, that is morbid type 1 second degree heart block, or you may be given a left bundle branch block or right bundle branch block. Very easy one, anyone can diagnose. Those are the things. And also you may be given ECGs of tachyarrhythmias like atrial fibrillation, that's common actually, and also you may be given SVTs. So few things only. So that we'll be doing in this ECG class. So that's the program. That is the way we are going to do this class. I gave you a brief overview. I hope you enjoyed this series of lectures. 2 free classes yesterday and today.